All right. So here we are in this week's lecture content, and I did just upload all of those forms. So this is the care plan and the study guide. This is the med sheets and the system disorder form. So if you want to follow along. And then I just want to point out BrainFuse, our tutoring option. So I have more stuff up on my banner. So BrainFuse will be right here for you. For me, I have to click on it and then go to it. Okay, but BrainFuse is always here. You don't have to be assigned it. You can use it whenever you feel like you need it. So you can like hop on and take a chance. Maybe there's somebody like right now that you can tutor with, or not right now, but whenever you're at home and you want to use it. Other times you'd open it up and you'd schedule an appointment. Okay, and you can like upload your study guides, you can upload activities that we've been doing, you can share anything with them and then say, you know, talk to me more about this, let's work more through this. Okay, so even though sometimes I do assign it to students, you don't have to be assigned BrainFuse to get into it. You can use it whenever and wherever you would like. Okay, so I just wanted to point all that out. All right, so let's go through here what you would have come up with here. So this first one, zoom out a little bit here. Okay, so fluid volume deficit is what we identified. That's our main problem. That's really with her labs and all of her assessment data. That should have been the first one, the primary one that jumped out at you, is fluid volume deficit. All right, so fluid volume deficit. Related to is the cause. Okay, so in your guide it says excessive loss, and then in parentheses it does say vomiting, diarrhea, things like that. So for her specifically, it's vomiting, which falls under excessive loss, right? So she's losing more than she's taking in, so you get the deficit. Other ones are the increased fluid requirements because she's got something going on. She's got a bit of a fever, which we said kicks up your metabolism. So you're going to need more fluid if you have a fever and your metabolism is up a little bit. Okay, so that's another cause. And then a third cause I identified is just having diabetes. Okay, so having diabetes, it has to do with your metabolism and how you take in nutrients and distribute them through your body. So those are three you could have come up with. Vomiting is the main one. That's the main specific cause. Okay, and then the as evidenced by is all the signs and symptoms that go with this problem. Okay, so the ones that go with this problem are that hematocrit being a little bit high, right, because things are kind of concentrated. The BUN being elevated, again, because of concentration. Creatinine being elevated. We didn't go into much detail about that, but it tells us about fluid status and it tells us about kidney function, right? Also, the sodium being elevated. Okay, so those are the labs that go with fluid volume deficit. And then the assessment data, the dry mucous membranes, the numbness and the tingling in the fingertips and the toes, the prolonged cap refill, the weak pulses, the tenting, right, when we pinch their skin and it sticks, it doesn't really go down like it's supposed to, the tachycardia and the hypotension. Okay, all of those are data, are clues that would lead you, if you group them all together with the cause, that help you find out that she's got fluid volume deficit or deficient fluid volume. Okay, so a goal, just a generalized goal, the patient will have improved hydration status. That would be enough, but depending on what instructors you have, they want more information. So you could say as evidenced by normalized vital signs, improved skin turgor, and adequate urine output. Okay, so the goal is they're deficient. We want them to have normal or improved, and this is how we will know that she's reached that goal. Okay, the interventions that you would have come up with, and you would have pulled them just right out of that website. Remember, our interventions are not just giving medications. They're things like monitor, assess, encourage, educate, provide. All of those adjectives, those descriptive words are all for our interventions. Okay, so we're going to monitor vital signs frequently, administer fluids as prescribed, PO and or IV, monitor intake and output, assess the skin turgor, encourage to avoid alcohol and caffeine, right, because those are diuretics. They cause us to pee more than we normally would. Provide oral care, again, because of the dry mucous membranes, she's dehydrated. Educate the patient on all of those things, and then monitor for overload. Now, too much of a good thing if we start giving IV fluids and we don't keep reassessing, Now we can flip her the other direction and put her in an overload state, okay? So just monitor for that, if they're continuing to get IV fluids. There. All right, and then the other one, the next one, imbalanced nutrition greater than body requirements related to diet and sedentary lifestyle. So if you look at your causes, diet and sedentary lifestyle, high calorie diet are the reasons. Okay, that's what causes it. Over here to the side, I just made myself a little note of what the normals are. Again, cholesterol should be less than 200, triglycerides less than 150, LDL less than 100, and then the HDL should be over 50 or over 40 in men. Okay, so the data then that lets me know that this is the problem, that BMI, the cholesterol, triglyceride, LDL, and HDL level, also the dyspnea on exertion, and then also that abnormal glucose of 160. Okay, so all those reasons. The goals, this one here was on your website. Patient will demonstrate behavior changes to reduce calorie intake and increase physical activity within 1 to 2 weeks. So that's great. But then one for like specifically during your time with the patient will make healthy meal choices with the assistance of nursing and dietary during stay. Okay, so you can only control what you can control while they're there. You know, once they leave, you really can't help them with any of this. But this first goal would be something that you can focus on while you have them in the hospital. Okay, and then the interventions that you would have pulled out. First, we have to assess the dietary habits, calorie intake, and portion sizes. So in your reading, it talked about like a food diary and all of that. So we don't know what changes need to be made if we don't know what they're doing already. So that's the first step. We're gonna monitor the weight, the BMI, waist circumference is thrown in there. We don't see that as much. If the patient, you know, had a dietitian or somebody that they went and met with, they would do all those specific things. Collaborate with the dietitian for an individualized weight management plan, encourage gradual increase in physical activity, promote behavioral strategies, including the food diaries, meal planning, and mindful eating. So that just means like not eating on the go and rush, like sitting down and thinking about what you're eating. Monitoring the vital signs and those labs that were listed above. Educate on healthy food choices, portion control, and reading nutrition labels. That's a big part of it, is just, you know, what am I putting in my body? So showing the patients how to read those labels. Encourage support groups or counseling, and then discussing a med review. Maybe there's some medications that your patient takes that are contributing to weight gain. And then again, just encourage gradual, sustainable weight loss. Nothing crazy or dramatic, because those don't last, right? And it's not healthy. All right, and then our last one here. We've got the risk for imbalanced blood glucose because they have diabetes. So like I said earlier, any diabetic patient, we're always worried about that imbalance, either too high or too low. So either way, they can flip on a dime. So just always being aware of that risk. Other causes are the alcohol consumption and then infection, right? So we have the signs and symptoms. We don't have the results of the urinalysis yet, right? It was ordered, but there were no results in there yet. White count was still normal at this point, but she's got a fever. So maybe there's some type of infection going on. Once we get those results back, it sounds like maybe a UTI is going on, but we don't have all that data yet. Okay, so the goal then is just that they'll maintain blood glucose within the prescribed range during hospitalization. Okay, the interventions that we're gonna do for that, oh, this cut off down here. And then I ran out of room, so I put this on the side, but monitor blood glucose regularly. So we're gonna continually do those AccuChecks and see where the patient is at. Assess for signs and symptoms of high or low blood sugar, right? So warm and dry, sugar high, cold and clammy, need some candy, right? So just being aware of those changes so that we can go ahead and then check their blood sugar if they're showing any of those signs. Administer insulin and oral hypoglycemics as prescribed, and then evaluate the effectiveness of those. Encourage consistent meal timing with balanced carbs, protein, and fiber, which is a subcategory of those carbohydrates. Okay, so consistency is key for our diabetic patients. They can't have like, I don't eat all day and then I have a big meal at night and then the next day maybe I eat a few small meals. Like they really have to be consistent breakfast, lunch, dinner, snacks, like all of that, because then their medications that they take on a routine work with what they're eating. So consistency and planning is key for these diabetic patients. Educate on how to check your blood sugar, how to take your medications, if insulin is involved, how to do that. Instruct on the rule of 15, so 15 grams of sugar or carbohydrate. That would be something like a glucose tablet, 4 ounces of juice, maybe a tablespoon of honey are all examples, and then recheck in 15 minutes. Okay, so that would be for hypoglycemia. If we check them and they're low, we're gonna give them some type of sugar, some glucose to bring it up, and then we're not just gonna say it's probably good now, then we have to recheck and make sure that it has come up. Okay, monitor for infection, stress, and steroid use. Those are all things that will cause the blood sugar to go up and increase. Promote regular physical activity. It says collaborate with dietitian and diabetes educator. And then the last one is encourage a med alert bracelet, just so we know, if they're cold and clammy, kind of getting confused, maybe they're not having a stroke, but maybe it's low blood sugar, so we would know to check that. All right, I'm not gonna go to the study guide yet. I'm gonna go to the other worksheets and then we'll come back to the study guide. Alright, okay, so system disorder. So for this, you guys use your MedSurg book that should have most of the diagnoses, the medical diagnoses that we're working with. And then you can just use like the chapters that were assigned, your drug book, things like that to help you get all the pieces and parts. Okay, the most important thing, and this is something that you should be doing in your clinical paperwork too, I think only about half of you got this part, is alterations in health, in parentheses, it's diagnosis. That's your nursing diagnosis. Okay, so some of you were putting like the patho here and here, or just listing signs and symptoms here. This is your nursing diagnosis. So all of this you get from your resources. This you have to do some critical thinking. So based on this, what is my nursing diagnosis? Okay, so for hypervolemia, the main one is fluid volume excess, or excess fluid volume, either way, is the main nursing diagnosis. Some other ones you may have come up with is like risk for impaired gas exchange because of the congestion in the cardiopulmonary system, but the main one was just fluid volume excess. Okay, and then patho is what is it? It's fluid retention or excessive intake, which increases the circulating volume. And then if the fluids leak into the tissues, then you're seeing some edema and some organ strain. Okay, so that's what's going on in the body. Health promotion, right? We want to limit sodium intake because we know that when you have a lot of sodium, it causes you to retain fluid. So that's going to contribute more to the hypervolemia. We're going to monitor their fluid intake, and they should weigh themselves daily, especially if they're a heart failure or a renal patient, a kidney patient, a dialysis patient. Okay, so limit sodium, monitor fluids that we're taking in at home, and weigh ourselves daily. Okay, risk factors. Okay, so things that can be occurring that puts you or your patient at risk for fluid volume excess. Again, that high sodium intake. If we're doing IV fluids, we have to be aware of when the cutoff should be. Heart failure, kidney failure, okay, and then also our liver disease patients or cirrhosis. We talked about those patients back with assessment. We said those are like usually like the skinny men that look like they're 9 months pregnant. They have that firm, distended abdomen. It's because they have liver disease, so their liver isn't cycling all the fluid through, so it's building up in their abdomen. Okay, so those are risk factors, so things that could occur and then cause this problem. Okay, and then once we have this problem and we're doing our assessment, what are we gonna see? Okay, so tachycardia, with hypervolemia, it's gonna be a bounding tachycardia, so very strong, like +4 pulse. High blood pressure, When it backs up to the lungs, we're seeing crackles and shortness of breath, which is the dyspnea. We're seeing the edema, maybe the JVD, jugular venous distension, and then the weight gain. Okay, so those are the expected findings. Our laboratory tests, which were in our case studies and our activities that we've been doing, the hematocrit is going to be low, BUN is going to be low because of the dilution, right? And then urine-specific gravity is like the weights or the contents of the urine. So again, it's going to be low, it's going to be more dilute. And then low serum osmolarity means just like our blood, our plasma, we're going to be more dilute, right? Because we've got too much fluid. Diagnostic procedures, again, the daily weight, hemodynamic monitoring, which is just blood pressure, pulse ox, that's all hemodynamic monitoring. So if they're on a regular med-surg unit, we check that manually. If they're in the intensive care unit, they'll have like a central line that will give us all of those readings in real time. Okay, so hemodynamic monitoring. And then for hypervolemia, we're also gonna see chest x-rays. So if you have a patient in clinical who's admitted with CHF or hypervolemia, you should see a chest x-ray from that first day, and then you should see at least one, maybe other ones each day to kind of track and progress, and hopefully the lungs should be clearing out that extra fluid. Okay, so when fluid is in the lungs, that's called pulmonary edema. Okay, so then the safety considerations then for that patient are gonna be the pulmonary edema risk, and off to the side that says airway. Okay, so if their lungs are filling up with fluid, we're worried about their airway, right? Their breathing. Okay, so that's a risk. Another risk is fall risk, right? Just because of all their vitals and everything, they're not gonna be as steady. And then because of the treatment now that we're gonna give, right, we're probably gonna give diuretics, so we're worried about the potassium drawing. Okay, so those are all potential safety risks. Okay, complications, again, are gonna be that pulmonary edema, heart failure exacerbation for our patients who do have heart failure that are not watching the fluid intake, not watching the sodium intake. They can have what's called exacerbation, right? So once they have heart failure, they always have it, but as long as they're doing what they're supposed to be doing, taking their medications, they're kind of in like a remission state. Once we see them in the hospital, that's called when they're in an exacerbation. So it's like flaring up because they're not doing the things, or they get sick, or whatever it might be. Okay, and then also just going along with the signs and symptoms and everything, we worry about hypertensive crisis. So we know their blood pressure goes up, but it could go like crazy high up to where now we're worried about like a stroke immediately. Okay, patient-centered care. So the nursing care that we're gonna provide, we're gonna monitor the vital signs, we're gonna have strict I&O, we're gonna weigh them daily, we're gonna assess their lung sounds, we're gonna position their head of bed up, again, because with the fluid overload, it can back up into their cardiopulmonary system. We're worried about their oxygenation. So we're not gonna be laying them flat to where they're having a difficult time breathing. We're gonna monitor or assess their edema. So if initially they come in, they've got like 3+ pitting edema, with our treatments and then managing their diet in the hospital, we should see that gradually improve. So we would assess for that. Okay, so just because you had a nurse who prior to your clinical day documented +3, right? Go in, do your assessment, it might be only +1 for you today. Okay, so that's our, our baseline data, but we always wanna do our assessment, because hopefully it is changing. Hopefully the data is improving. Okay, and then fluid and sodium restriction. So all those things would be things that we would be thinking about when we're taking care of that patient. Therapeutic procedures, again, are gonna be the fluid restriction, oxygen therapy if needed, and then if they are a kidney patient or a renal patient, maybe they do need dialysis to get this extra fluid out. Okay, because remember, our kidneys are what helps regulate and says this needs to go, this needs to stay. So if they're not working, that's where hemodialysis comes in. We hook them up to the machines and then we pull out the extra fluid. Okay, medications then, diuretics, that furosemide is gonna be that main one that you're gonna think about and see with these patients. And then again, depending on what's going on, maybe some antihypertensives. Client education, again, focusing on limiting the fluids, limiting the sodium. to take their weights daily at home and report a 1 to 2 pound increase over 24 hours. And so if they have that, they need to let their provider know. And then medication adherence, so the Lasix, maybe they're taking that digoxin to manage the strength of their heart pumping and slow it down so it's more efficient and can move that fluid. Okay, so just making sure they know how to take their medications, they're taking them routinely when they're supposed to. Because even for these patients, just one missed dose can throw them into exacerbation. Interprofessional care, so the other people that we'll be talking to, when your patient's admitted, they have like their general primary doctor. In the hospital, a lot of them are hospitalists. You may have some outside providers that are coming in, but nowadays they refer to everyone, so they get everybody on board. Back in the beginning of time, one doctor did all these things, but now we can get much more people involved. So cardiology, they're gonna manage the heart failure specifically and manage those medications. Nephrology is the kidney doctor, especially if they're developing some kidney disease, for sure if they're already a dialysis patient. RT is respiratory therapy, so if oxygen is needed, if they're to the point where oxygen is impaired, respiratory therapy will be consulted to come in and manage that. And then pulmonology would be the lung doctor if they've got some backup into their lungs. Okay, and then again, complications are gonna be that pulmonary priority. All right, so that one is too much, and then the next one is too little. Okay, so hypovolemia. So the main nursing diagnosis you should have identified is fluid volume deficit or deficient fluid volume. So one student who had 2 extra ones, which were really great, they had decreased cardiac output and they had impaired peripheral perfusion, right? Because we just don't have the volume, so we're not gonna be pumping it out and it's not gonna be reaching our extremities. So those were 2 good ones to add. Okay, so what's going on in the body? It's a loss of fluids, decreased circulating volume, and decreased tissue perfusion. Okay, so we just don't have it, so it's not there to reach all the extremities and the tissues. Okay, health promotion and disease prevention. Make sure they're getting that baseline amount, 2 to 3 liters, unless contraindicated, right? So the heart failure, the kidney disease patients. Early treatment for vomiting and diarrhea. So if the patient's having excessive loss, especially if they've got chronic conditions that they take all kinds of medicines for, they don't wanna wait, they wanna get a hold of their provider right now so they can give them some extra instruction of what to do with your medications, or most likely they'll want them to come into the office and be seen. Okay, and then monitor those high-risk patients. The elderly, right, we said as we age, our fluid composition change and we have decreased kidney function, so we're at increased risk for not being able to maintain that homeostasis. Post-op patients, and then patients that are getting diuretics, okay, are gonna be the high risk. All right, risk factors or causes that you would see this: vomiting, diarrhea, GI suction, so those patients that we've have to put an NG tube down and suck everything out. If they have like an obstruction, like that patient we talked about yesterday, we have to make them NPO and then try to suck all of that waste out. Okay, hemorrhage, again, if they're just bleeding out, their volume is gonna go down. A burn patient, because your skin keeps your fluids in, so if you burn off your skin, you're leaking out all your fluids, so these patients are gonna be dehydrated. Diuretic use, like we've been saying. Diaphoresis is sweating, so like if they're very sick and they have a fever, or just somebody who like exercises a lot and runs a lot, when you sweat, you lose your fluid, so you could be risk for hypovolemia. Decreased intake, of course, if you're not getting that baseline amount, and then again, kidney disease. Okay, so what we're gonna see, what we've been working on with our activities and our case studies. Tachycardia, again, remember, but this time it's gonna be weak, okay? And it's not gonna be as a result of all this fluid volume we have to move. It's because your body knows, your brain and your heart knows that you're not getting perfused, so you're gonna increase the rate to try to perfuse. So it's tachycardia again, but this time it's a weak, thready pulse, because you just don't have that volume, okay? And you will see now the blood pressure is gonna be low, because we just don't have the volume. Having to do with that decreased perfusion, we're gonna see the pool, clammy skin, poor skin turgor, decreased urine output, What does come out is gonna be concentrated and really dark, maybe some dizziness, confusion, okay, because we're just not getting perfusion to the brain. Those dry mucous membranes, and then weight loss now. Safety considerations, again, fall risk, just because of all their assessment data being out of whack. And then replacing fluids, now monitor for fluid overload, okay? So just like when we give insulin for diabetes, for blood sugar being too high, we can drop them down too low. When we give blood pressure meds for blood pressure being too high, we can drop them down too low, okay? Same thing, when we're replacing fluid, we're not just done, call it a day, we can tip them to the other side of that scale. Labs now, or these main ones, are gonna be the opposite, okay? So with hypovolemia, hematocrit's gonna be high, BUN is gonna be high, because everything is really concentrated. Once we, balance them out, it should go back to normal. Again, unless they do have an underlying kidney disease or anemia of some type. Okay, increased serum osmolality, so again, just the concentration of the blood, it's gonna be like thicker, more concentrated. And then the urine that does come out is gonna be concentrated, so the specific gravity is just like the weight of it is gonna be higher, okay, so the opposite. Diagnostic procedures are the same, except for we don't have to worry about chest x-ray because there's no fluid overload, but that daily weight, hemodynamic monitoring, and on this one I wrote it out for you, it's blood pressure, pulse, O2 stat. And then what are we gonna do for the patient? Really same stuff, most of it. Monitor vital signs, strip diagnose, daily weight, assessing the skin turgor, the mucous membranes, monitor those labs, and then fall precautions for the patient. Therapeutic procedures, IV fluids, normal saline is usually what we start with, right? That's isotonic, so it's not gonna cause a change in or out of the cells. It's just gonna go where your body needs it to go. And then blood transfusion, it just depends. If the cause is hemorrhage and all of their red counts are actually low, then maybe that's what they need. For a patient who had like a GI bleed, maybe they could also have some hypovolemia and it's because of hemorrhage, so then they would need a blood transfusion. Okay, so the medications are gonna be the same then. IV fluids, usually normal saline or that 0.9% is our main one, and then blood just if needed. Education now is to increase their fluid intake, and then signs and symptoms to report, the dizziness and the low urine output. Okay, people who we're gonna work with, the provider, it's usually just a general provider. They usually don't consult specialties, again, unless there's a specific cause that goes with that specialty. We need them to order the IV fluids and then blood if that's needed. And then maybe the dietitian can help us with fluid plan. All right, complications then for this patient are gonna be acute kidney injury. So kidney disease, just from not perfusing our kidneys, and from becoming in a dehydrated state, you can cause kidney injury. So maybe this type of patient, they'll have like an acute incidence where they're really dehydrated, and you might see a patient who has to have maybe just an initial consult, but that doesn't mean they would continue on with a nephrologist or have to be a dialysis patient or anything like that. Okay, and then hypovolemic shock. There's different types of shock. So like cardiogenic shock is when you have a heart attack and your body like shuts down. Hypovolemic shock is when your body's shutting down because you don't have what you need in terms of fluid volume. All right, so that's our system disorders. Let's go through our medications. So atorvastatin or Lipitor is one of the first ones back from nutrition content. Okay, atorvastatin, it is a statin. Okay, so if you see the last name statin, and you see simvastatin, lovastatin, and those are the common statins, and they're all for high cholesterol or high lipids. Okay, in your class it's an anti-lipemic. Okay, so if you think of lipids or fats, okay, that's where the cholesterol and everything goes into play. So it's an anti-lipemic. It's a HMG-CoA reductase inhibitor or just a statin. No one ever says this or thinks about that. We just call it a statin or an anti-lipemic. Okay, and that was in chapter 21. All right, so expected farm action is what it does in the body. So that's usually more scientific terms. And then therapeutic use is like generic, plain language for a patient. So it inhibits cholesterol production in the liver, resulting in lower of the bad cholesterol and higher of the good cholesterol. So therapeutic use then is to lower the cholesterol, and then why specifically? Because it prevents cardiovascular events like MI or stroke. Okay, so if our cholesterol is high, that means that it's just sitting in all of our vessels, so it's narrowing the space for our blood to move. There's little plaques, it's like sticky, so they can like break off and travel, so that can result in heart attack and stroke. Okay, so we give this medication to lower the cholesterol, but because we know if we don't lower it, they're at a high risk for heart attack and stroke. Complications with this one, the most common one is GI upset, so like nausea, vomiting, diarrhea, abdominal pain, bloating, all that falls under GI upset. And then myopathy or rhabdomyolysis is muscle pain. Rhabdomyolysis is your body like breaking down your muscle tissue, and then it causes pain, confusion, it messes up all their lab work. And then hepatotoxicity is gonna be your liver toxicity. Okay. Administration, we give it once daily, usually in the evening. Why in the evening? Because while we're sleeping, our liver makes cholesterol at night. So, we need cholesterol, we need the good cholesterol, we need fats and stuff. We just don't need the bad kind, and we don't need too much. So our liver makes it at night, so if we give it in the evening, that's the maximum time for it to work and kind of slow down the production of excess cholesterol. We can give it with or without food, and it only comes as Benpeo in the pill. Contraindicated then if they already have liver disease. So we said we're worried about hepatotoxicity, which is like inflammation, irritation of the liver. So if they already have liver disease, it would be contraindicated. Most drugs are contraindicated in pregnancy. There's a few that are okay, but this one is not. So if the patient is pregnant, we wouldn't give it. And then heavy alcohol use, again, because it can be so damaging to the liver, so is alcohol. So if they're already damaging their liver with lots of alcohol, we wouldn't want to give them this. This is one of those funny ones that interacts with grapefruit juice, and then I usually say, who even drinks grapefruit juice? And then I usually have at least one person that says, my grandma has grapefruit every morning, so there you go. So don't give it with grapefruit juice. They interact together. And then other lipid lowering agents, like you've probably already seen in the nursing home, in the hospital, these patients aren't just taking 1, 2, 3 medications, they take a boatload and all of like the same kind. So you might have a patient who takes multiple cholesterol meds. Okay, so that's just gonna increase that myopathy risk, that muscle pain. All right, nursing interventions then, how do we know that it's doing what it's supposed to do? We're gonna monitor the lipid levels. So that was the cholesterol, triglycerides, LDL, HDL. We're gonna watch those. Those are usually just like a every 3-month or every 6-month lab draw. That's not like our CBC and our BNP that are every single day when they're in the hospital, because they don't change that quickly. We're gonna assess them for muscle pain and the weakness, so we can catch those side effects quickly, and then monitor liver enzymes, which in your study guide we'll see the BMP, the basic metabolic panel just has like your main electrolytes, where the CMP, the comprehensive metabolic panel, also has your liver enzymes. Okay, so specifically the AST, ALT, they would be elevated if your patient's having damage to their liver. Okay, patient education is always gonna go back to the cause, so hopefully we can kind of decrease your dose, maybe get you off of this medication, so diet and exercise. Anytime you give a cholesterol med, you're gonna kind of have that conversation, avoid grapefruit juice, and then report muscle pain. Okay, so it all goes back to the cause and then the side effects that you might see. All right, and then how do you know that it's effective? It decreases the cholesterol. So the cholesterol is the substance used by the body. The LDL it's like a protein carrier, so it carries cholesterol to your cells. We don't want it in our cells. So if we have a high LDL and high cholesterol, it's all staying in the body. Side note, HDL, the good one that we want to be higher, carries cholesterol to the liver to break it down and remove it. Okay, so we want more of this HDL to get the cholesterol out of our body. All right, so that's atorvastatin. Okay, our next one is metformin or glucophage. You probably had a lot of nursing home patients take this. We really don't see it in the hospital as much anymore because of this contraindication right here. So we'll get to that. Okay, so it's an oral anti-diabetic. The subclass is a biguanide. We don't ever really think about that or use that. It's an anti-diabetic. Okay, so it's for a patient with type 2 diabetes only, not for type 1 diabetes. Those patients need insulin, and the way that this works is it decreases your glucose production, so that's good, but also it increases the sensitivity to the insulin that your body is making. So if you're type 2 diabetic, you're still making insulin, you're just not making enough as you should. So metformin will help increase the sensitivity to what your body is already doing. If you're a type 1 diabetic, you're not making any insulin at all, so this drug will not help at all. Okay, so those patients just use insulin. Okay. Complications then with this one, you'll see GI upset, so nausea, vomiting, diarrhea, bloating. It's a common side effect that you'll see. And so then if, depending on how bad it is, then you're worried about maybe vitamin deficiency. Because remember from nutrition, as things move through your GI tract at the regular rate, things are absorbed, right? The nutrients are absorbed, water is absorbed back, all of that, things that are supposed to happen. If they're having, diarrhea or anything like that, things are gonna move very quickly, so those nutrients aren't being absorbed, so you're worried about deficiency there. Okay, and then also, just too much of a good thing, now we're worried about hypoglycemia. And then lactic acidosis. So metformin, it decreases the liver's ability to clear lactate, which is an acid in your body. Okay, so if there's a buildup of it, then your patient can become in an acidotic state. So you read a little bit about that in fluids and electrolytes, but we're kind of sticking much more basic. So next semester, you'll talk more about acidosis, alkalosis, things like that. And then in the next 3 semesters, you will. Okay, so that's kind of above us, but I'm like a why person. Like once, if I see it, I have to know why, so I have to put all that in there. All right, Metadmin, take it with meals, and it's by mouth. Okay, so take it with meals so it can do what it's supposed to do and work on the food that they're eating. Okay, contraindications then. So this is why we usually don't see it in the hospital, because we don't always know right when you're admitted if we're gonna need to do a test with contrast dye. So remember with contrast dye, we inject it either in a vein or like in your slides you saw like you could do a barium enema. So like if your patient, if we're looking for like tumors or like fistulas or things like that, they could do a barium enema where they give them an enema of contrast dye and then they go have an x-ray and they can see, oh yeah, there's a connection here that shouldn't be, or anything they can find in there. Okay, otherwise we usually give them in their IV and it goes through their vascular system, which will then go to their kidneys, it'll light up their kidneys, anything. Okay, but using the contrast dye with metformin then increases that chance of lactic acidosis or them becoming in an acidotic state. We can't give metformin 24 hours before and 48 hours after contrast dye, so you usually won't see it. Okay, so your patient maybe only takes metformin at home, they never take insulin, but when they're admitted to the hospital, they won't be getting metformin and they will be getting insulin. Okay, so you just kind of have to know the background. Maybe once their, whatever their problem is resolved, they won't be on insulin once they go back home. Okay, but that's why we don't use it. Again, also if they have kidney impairment, just because it can build up and cause damage, and then with severe infection are the contraindications. Right, interactions then. The alcohol and the contrast dye, again for the same reason, can result in lactic acidosis and then kidney failure. Nursing interventions, monitor their blood glucose or blood sugar, hold it after and before. Sometimes I use those little abbreviations, so I gave you a little key. those contrast procedures, and then monitor the renal function. Okay, all that goes together. How do we know if it's effective? Their blood glucose is controlled, so those AccuChecks that we're checking 4 times a day or whatever, and then their A1C, which is usually every 3 months, 6 months, somewhere in between there, they'll check it, and that's more of a long-term snapshot of what their blood sugars have been. Okay, so that's how we know it's effective. Client education is to take it with the food, avoid the alcohol, and report any weakness. That's gonna be a sign of that lactic acidosis happening. Okay, and then side note, again, because I just like to know why, lactic acidosis happens when the body is not getting enough oxygen, so the cells make acid instead of energy. All right, so that's metformin. All right, so we've got cholesterol and we've got a diabetic one. All right, and then this one, this drug ondansetron or Zofran, it's an antiemetic. We think of emesis as vomiting. If you've ever seen an emesis basin, it's like shaped like a kidney. It's a tiny little basin, which is not enough, right? We like those big bags that collapse on each other. Those are good. But emesis means vomiting, so an antiemetic is gonna prevent you from vomiting. Okay, it's also a serotonin antagonist. We don't really ever think about that subcategory, but how it works in the body is it blocks the serotonin receptors in the central nervous system, and it suppresses the vomiting reflex. Why do we give it? It prevents nausea and vomiting. Okay. Side effects are going to be drowsiness, constipation, or diarrhea, which is kind of funny. It just depends on your body and your genetic makeup. It could go either way for you. Okay, and then headache. And then QT prolongation, that goes with cardiac dysrhythmias. So when like 3rd, 4th semester, you're gonna learn how to read an EKG. So in clinical, you've seen the telemetry and you've seen the rhythm. So the nurses will print out that and they have to like measure all these different parts, like the PRI and the QRS and all of that. That just means that a part that's supposed to be shorter, so it's only supposed to take this much space, takes longer. And if it takes longer, that means that they are at risk for an arrhythmia. Okay, so that's just about reading their EKG. It's their electrical heart rhythm. So it's not what it's supposed to be. So when it's not what it's supposed to be, they can go into VTAC or even like asystole, so like bad dysrhythmias where they could go into a code. So those are the side effects. This is rare, barely ever happens. Okay, drowsiness pretty much always happens. These other ones, not so much. How do we give it? Comes in PO. But if they're already vomiting, we're not gonna give it for PO. We would give it PO as preventative. If we're going to do something where we know we get sick or something, PO would be okay. In the hospital, when they're sick and throwing up, we give it IV. And it works really great, and it also makes them a little bit drowsy, which if you're up and you're nauseous and you're vomiting, you want to stop feeling that way and you want to sleep. So it is a very great drug for our patients who are very sick. So we give it IV. And then ODT, you guys remember that's the orally disintegrating tablet. So that, if they don't have IV access and they're actually vomiting, we could do the ODT because it just dissolves in their mouth and then it's absorbed in the capillaries right into the cardiovascular system. All right, so if we know what the trigger is and we can time it, we'll give it before. If they're already vomiting, we definitely want to give it IV. Okay, contraindicated then, really the only contraindication is if they already have a dysrhythmia and we already know based on their EKG that they have this situation with the QT interval. Otherwise, it's a pretty safe drug.
Ms. Ron,
Yeah.
what's QT prolongation? I don't know how to say it.
Prolongation. Yeah, so that's just on the EKG that we see. So you'll see there's the P wave is the atria contracting. And then the QRS is the ventricles contracting. And then the T wave is the repolarization or like the resetting of the ventricles to get ready to go again. The atria has a resetting to get ready to go again, but it's lost in the QRS because that's a much stronger impulse. And again, you'll talk more about this later on. So it just means that after the ventricles contract and then they're resetting, that time frame, there's a time frame that's a normal time frame. So they kind of measure it with their little calipers. So this is longer than it's supposed to be. So they're prime for an arrhythmia.
So it's taking the ventricles longer to reset.
Yes. Okay, so interactions, opioids and alcohol, just because of the way it works, back in the beginning, it said it depresses the central nervous system. It's really not like a strong, like an opioid or anything, but now if we start adding opioids and alcohol, which are also central nervous system suppressants, we can worry about, respiratory depression, lethargy, things like that, our patient kind of being out of it. Okay, how do we know it's working? They're not as nauseous, they're not vomiting. Interventions, assess then nausea and vomiting. Control environmental triggers when able. So you know how when you're sick and throwing up, lights bother you, smells bother you, like everything bothers you. So be aware of that for your patient. If they're sick and throwing up, control that environment as best as you can. And then monitor the ECG or EKG in those high-risk patients. Okay, again, but that's very rare. We don't usually see that. It's a pretty gentle drug. Client education, we let them know what it can cause, drowsiness, so like you're not gonna take this, I'm not gonna give it IV and then you're gonna like do your homework if you're in the hospital or something, it's gonna make you go to sleep. Could cause headache, so just like fluids can kind of help with that. Let them know that it could affect their bowel elimination, and then again, if they're feeling an irregular heartbeat, to let us know. Right, and then so we've got cholesterol, we've got diabetes, we've got nausea and vomiting to prevent that fluid volume deficit, and then now we've got for if they're having constipation. Okay, so DocuSet sodium, which sodium is just like the second part of the drug. We usually don't even say it. It doesn't mean that it's full of sodium or anything and it does anything to your sodium level. It's just the second name of the drug. Okay, it goes by Colace, that's the brand name. It's categorized as a surfactant laxative, but I told you all yesterday that it's really just a stool softener. Okay, so it doesn't make you go, we're not gonna give Colace and they're immediately gonna run to the bathroom. It's a daily thing, and they also should focus on fluids and diet and all of that. Okay, so it's just a routine everyday med. Okay, it's a stool softener. How it works in the body, it allows water and fat into the stool, okay, which then softens the stool. Okay, so it's only gonna work if the patient is drinking water. Okay, so if they're dehydrated, they're not drinking water, and we give them Colace, it's not gonna do anything. Okay, so the fluids really have to help. Why do we give it? It prevents constipation and it softens the stool. Complications, maybe mild cramping, because it's doing what it's supposed to do, it's getting things moving. And then if our patients are abusing it, you could see diarrhea with overuse. Okay, this is one of those drugs that's prescription, but it's also over the counter, so anybody can go get it and take it as much as they would like, I guess. Right, it's contraindicated if they have a bowel obstruction, right? Because no matter what we throw in there, the outlet is blocked, so they need an NG tube and bowel rest, so we wouldn't give it with that. Again, it's a pretty gentle medication, really not many side effects. It is PO, we need to give it with that full glass of water so that it can work for them. We're gonna monitor their output, assess for any abdominal pain. There's really nothing it interacts with. We know it's working if they do have soft form stools and easier bowel movements. And then education, increasing the fluids, fiber, and then get them up walk, all that. Right, and then our last drug sheet, and then we'll go to the study guide. So Colace is for if they're not going, if they're constipated. Loperamide or Imodium is now for if they're going too much. Loperamide or Imodium, it's an anti-diarrheal. It slows the intestinal, that says mobility, it should say motility. The intestinal motility, so that's like the peristalsis of things moving. It slows that down, and then it increases the absorption of water. So we said after our food leaves the small intestine and goes to our large intestine, that's where water is reabsorbed. So it increases that action. So then the stool is gonna be more formed, more hard, so it's not gonna be diarrhea anymore. Okay, so that's what it's for. Complications then again are gonna be abdominal pain, and then now again, if we overdo it, now we're worried about constipation. It's PO after each loose stool up to, I have to look, I think it's like up to 6 times a day or something like that, we can give it for our patients. Contraindicated with toxic megacolon, that's an inflamed diluted colon, and it can rupture. So that's like a specific diagnosis, so you would know if your patient has it. And again, it's contraindicated in pregnancy. That Colace one, the gentle one, was okay in pregnancy. Right? Other antidiarrheals, again, they can interact with, so just compounding what that drug does. Interventions, monitor their output. How do we know if it's effective? They're not gonna be having the loose stools anymore. Education, stay hydrated while you're having the diarrhea. It's for short-term use, so this isn't an everyday type of thing, it's just for acute situations. And then avoid caffeine, forgot the E at the end, and spicy foods with this situation because they cause diarrhea, right? Which our case study patient was doing yesterday, having spicy foods, and we talked about that. When they're having diarrhea, they wanna avoid that. All right, study guide. Study guide. Okay, so we've got all of these definitions here. So calories, that's energy that's stored in food. So as we read our food labels, it tells us how many calories per serving, and then we just have to figure out, how many servings we can use. Okay, so energy is stored in food, and then we get it, and that's from the macronutrients, right? Carbs, fats, proteins, and then we use it for any and all activities. Okay, so even if we're not getting up and running or exercising or doing anything like that, your body needs calories for your lungs to be inflating and deflating all day, for your heart to be pumping, for your peristalsis to be working, for all of those things, you need calories. And then walking, of course, any extra physical activity, you use calories. Okay, again, the macronutrients, I just said, provide energy in the form of calories, carbs, fats, and proteins. Our micronutrients are vitamins, minerals, and water. So we've got the fat-soluble vitamins, the addict vitamins, A, D, E, and K, and then B and C are the water-soluble vitamins. Okay, so to absorb A, D, E, and K, we have to have fat in our diet. To absorb B and C, we have to have water in our diet. Okay? And they don't give us calories, but they help us make use of the macronutrients. Okay, so they all work together. BMI categories, we had some activities on this. So just know your scales here. So underweight is under 18.5. Healthy is 18.5 to 24.9. Overweight is 25 to 29.9. Obese is 30 to 39.9. And then over 40, 40 or over is morbid obese. Dysphagia is difficulty swallowing. Dysphagia with a G, right? We said dysphagia with an S is difficulty speaking. NPO is nothing by mouth, okay, so they're not allowed to have anything. Sometimes you'll see like NPO accept sips of water, or NPO accept ice chips, whatever it is. Just know what your patient's diet order is. And then some of the diets that we read about, a regular diet is just a healthy, varied diet with all of those food groups. That's the MyPlate, right? So all of those groups should be included and just the right portion control. Soft diet is going to be soft and easy to digest, low in fiber, easy to swallow. So like mashed potatoes, bananas, Jell-O pudding, things like that. Pureed diet is foods that don't require chewing, so they'll include soft foods, and then also like they'll take meat or something and grind it up. They'll take vegetables and grind it up, so it's pureed so that your patient can have it and not choke on it. Okay? You want to know the difference between a clear liquid and a full liquid diet. So a clear liquid diet is only liquids that are clear, you can see through them. It includes popsicles because it's at room temperature. Okay, so at room temperature, a popsicle is a clear liquid. Popsicles, broth, Jell-O, juice. Tea or coffee is okay without any cream or anything in it. If you add the cream, now it becomes a full liquid. Okay, so clear is you can see through it. Full liquid, you can't see through it. So things like milk, pudding, custard, creamed soups, but nothing with like chicken noodle soup or something would not be clear liquid or full liquid because it's got chicken and noodles in it. Okay, so that's the difference there. Heart healthy diet, again, it's MyPlate, but with more of a focus. Even MyPlate, you want to watch, it doesn't include high sodium, but when we're thinking heart healthy, we're thinking low sodium, low fats, things like that. Vitamin K is one of the main of the vitamins that we talked about. We've been talking about it for a while now because we've been talking about Coumadin or warfarin, which is a blood thinner, and vitamin K works in the cascade of events that has to occur for your body to clot. So we said when you think of vitamin K, think of clotting. Okay, so it's responsible for blood clotting. It's in things like spinach, liver, kale, parsley, and butter, randomly. Okay, it reduces the effects of warfarin. Okay, so that's what we've been talking about it for. Aspiration is solids or liquids entering the lung. So you could see a patient who's admitted with pneumonia, and it's the specific type is aspiration pneumonia. It's because they were eating or drinking, and things went down the wrong pipe. They went into their lungs. They don't belong there, so then bacteria grows. So they have aspiration pneumonia. Hypoglycemia is our low blood sugar, less than 70. Glycemic index, foods have a high glycemic index or a low glycemic index. It has to do with their ability to raise blood sugar. We said foods that have a high glycemic index are like candy, white bread, donuts, things like that. And they spike it up very quick, but then they drop off. So they have like the sugar low. It's not good for diabetics because consistency is key, right? So our high fiber foods are gonna have a lower glycemic index, whole grains, starchy vegetables, things like that, where they have more of a steady blood sugar source. Antioxidants protect against free radicals, which can lead to cancer. So free radicals are like left in the body from exposure to pollution, from ingesting foods that we shouldn't be ingesting. Free radicals are these like extra little parts floating around in your body that are inflammatory, they're not good for you, and they can lead to cancer. Antioxidants are in all of our healthy foods, fruits, vegetables, whole grains, nuts, and eggs, which your book doesn't say. Your book hates eggs, I've noticed. It doesn't list eggs. Eggs are a superfood. Eggs are an amazing superfood. They've got everything you need, like antioxidants, also omega-3 fatty acids. Okay, so all these things, we have an antioxidant high diet. It will protect against those free radicals and decrease our chances of cancer. Okay, we also have omega-3 fatty acids in our foods, things like nuts, salmon, flaxseed, also eggs, which is not in your book. And what omega-3 fatty acids do are support brain health, reduce inflammation, and lower cholesterol. Okay, so all good things there. All right, summarize what you've learned about feeding tubes. Okay, so here's a picture of an NG feeding tube. In lab, you're working with like a PEG tube to practice your tube feed admin. Okay, so what you learned is that you can have an NG tube or a PEG tube. With an NG tube, X-ray is always needed to confirm placement initially. So when we first put it in and we put NG tubes in, doctors put PEG tubes in. When we put an NG tube in, we'll say, okay, it's in, you'll go down to X-ray, they'll get the image, and then as long as it's in the right spot, the radiologist will give us the order that it's okay to use it. So until we get that X-ray and until we get that order, we cannot use it. We can't put anything in it. Okay, to put it in, we take that tube, it's a big long tube, and we take the tip of it and we start at their nose, then we go to their earlobe, so we keep it here, stretch it here, and then stretch the last part to the bottom of the xiphoid process, which is the bottom of the sternum, and that's our mark. So we would mark that on that tube, and that's our goal. So then we're gonna have our patient, kind of lean down. We can start with them looking up, and then once it gets to the back of their throat, they look down. Sometimes we have them drink water to help pass it, but not all the time. And then we put it all the way down until it gets to that point that we had marked. Okay, so that's where we mark it off. We kind of tape it initially, not super secure because we might have to move it, but we tape it in place and then we send them down and then they come back up. If it's good, then we tape it securely. We use skin protectant on their nose and then we tape it in place. We're worried about, so here I have secured to the skin, we're worried about breakdown. So if it's like leaning up against one nostril, we're always gonna try to pull it away, make sure it can cause a pressure sore on their nose. Okay, same thing with the pen tube. We're worried about drainage from that tube leaking on their skin, so we're gonna assess that, make sure their skin is clean and dry. Alright, once it's good and we're using it, every time we go in to use it, we have to check placement before we put anything in it. Okay, there's lots of different ways. One of the ways is the measurement on the tube. So some of our tubes will have marking, so we'll say we put it in, it's all correct, and you'll see a number 24 right there. So we'll chart that, we'll say 24 is where it comes out of their right nostril or whatever it is. So every time we go in, we would make sure that 24 is still there. Okay, so the measurement on the tube, that would be checking the marker. Measuring the tube is another thing we do. So from where it exits the nares to the end of the tube, we measure it and we would say, you know, it's 12 inches or whatever it is. So that also gets documented. And then every time we would go to use it, we would measure that, it has to be 12 inches or whatever it is. Okay, so noting the marker on the tube, measuring the tube. Okay, and then we use air bolus. It's what we all use and love, but your books and NCLEX doesn't like it. So when it comes to that, don't choose it, but we all do it. So what it is we put our stethoscope over the stomach. We have our Toomey syringe, that big 60 ml syringe. We pull up 5-10 cc's of just air, and then while we're listening to the stomach, we push air, because air is okay, no liquids, no medicine. We push it and we should hear that like whoosh, we should hear it in there. So that's what we all do. NCLEX doesn't like it anymore. NCLEX likes these other things. So in addition to that, we aspirate and we look at the aspirate. Aspirate is also just stomach contents. So we pull it out, we look at it. It should be like green, brown, tan, yellowy color. So we look at it. And then we also, what NCLEX love is that we check the pH. I have yet to see a facility that does this. Anybody see it? You guys do it in your facilities? So you'd have a little pH strip, and you guys will practice this in lab. You'll do this in lab for your pen tube check off. So we'll have a little med cup with a pH strip, which changes color, you know, if there's acid or base. And we drop a little bit of that aspirate, that stomach contents in there, and the pH level or the acid level should be 5.5 or below. Okay, so I don't see that, but that's the one that NCLEX loves the most. Okay, so those are all the things we do. And then the last one is a CO2 detector. So like in an ICU unit, you might see it. And that's just telling you that it's in the lungs, it's in the wrong place. So if there'll be a little CO2 detector on their nose, or a little CO2 detector on the device, and so you can tell if there's carbon dioxide in it, but at that point it's already too late to know if it's in your patient's lungs. They'd be coughing, they'd be choking. Those would be the signs that you're looking at. Right, talked about that. Every 4 hours is how often we check it, if it's going continuously. Residual should be less than 200. When we're flushing it, so like the first step and the last step is to flush the tube, that's 30 to 60 mLs. If we're mixing medication with liquids, it's 15 to 30 mLs. Okay, and then that head of bed needs to be up whenever they're getting a tube feed. And if they're continuous, then their head of bed always needs to be up at least 30, 45 degrees. All right, so that's what we learned about NG tubes. Digestive organs and their functions. So these over here are the accessory organs. We talked about these a little bit yesterday. The liver, the gallbladder, the pancreas, they secrete bile. The liver makes bile, the gallbladder stores it and then secretes it, helps break down your fats. They also secrete digestive enzymes, which help break down your food, helps metabolize sugars through insulin, which comes from your pancreas. Okay, so remember there's veins that connect all of these organs to your small intestine, to your stomach. So they empty out all of these things and then they can work on the food to help it do what it needs to do. Main digestive organs that your food goes through is the mouth, then the back of the mouth is the pharynx, the esophagus, the stomach, the small intestine, and the large intestine. In the mouth, chemical and physical breakdown occurs, so you have enzymes in your mouth that start to break down carbohydrates, and then the chewing helps physically break it down. Pharynx just takes it to the esophagus. There is peristalsis, muscle contractions that occur in your esophagus to move it to the stomach. In the stomach, there's continued chemical and physical breakdown. And then in the small intestine is where most absorption of nutrients occurs. And then large intestine, we're reabsorbing the water, and then stool is forming. Okay. about reading food labels, so that's something, an easy thing that we can help our patients with. And then it asks how many calories are in 3 servings of this. It says amount per serving is 280. 280 times 3 would be 840. And you looked at the skill aspiration precautions. What is step 16 and what's the rationale? It was that you should check for difficulty swallowing after each bite and then stop further eating if the patient does have difficulty and notify the provider. Why do we do that? Because if we continue feeding them when they're having difficulty, they're gonna choke, right? So just being aware of that aspiration precautions seems like common sense, but I teach first semester clinical, so we need to have this on. All right, number 6, describe the significance of the loss of the balance between calorie intake and expenditure in relation to weight gain. So calorie intake is the calories that you're consuming from the things you're eating and drinking, right? A lot of us get caught with the drinks, the hidden stuff, the coffees, the sugary drinks and the sodas and things like that. Energy expenditure then is calories burned through just being alive plus exercise. Okay, so if they're balanced, we maintain our weight. If intake is higher than expenditure, weight goes up. If expenditure is higher than intake, then weight goes down. All right, some lab stuff here. So your BMP and CMP. So your BMP over here, we talked about all of these. I wrote down the normals over here off to the side. And again, you guys have this. I uploaded it to the course, so you have all this. It's right there in today's content. So these are our main electrolytes and kidney function. And then the CMP now adds some liver function, bilirubin, protein, albumin. Okay, so BMP, basic metabolic panel or profile. It's got our electrolytes, BUN is on there. CMP is comprehensive, so more advanced, more stuff. It also has the liver function. Right, some vocab here. A lot of this is repetitive, but it goes specifically with fluid volume deficit and excess. Tachycardia is over 100. Tachypnea is a respiratory rate over 20. Homeostasis is a state of equilibrium. Water and electrolytes at a constant level in the blood. Osmolality is the concentration of solutes to water. Osmosis is the movement of water from a more concentrated area to lower. Osmoreceptors and baroreceptors, you want to kind of think about those. So where those are located, your osmoreceptors, and there's pictures here and it explains, osmoreceptors are in the hypothalamus in the brain. Baroreceptors are in the aortic arch, which is where your aorta comes off your left ventricle. It comes up and then goes down, so that's the aortic arch. Carotid sinus is your carotid pulse, so right in there. So there's receptors in there. Those are baroreceptors. Baro means pressure, so you think of like, if you've heard in like weather, baro means pressure. So the baroreceptors detect changes in pressure. Okay, osmoreceptors detect changes in osmolality, so concentration. Okay, so those are built-in devices to help try to keep you in homeostasis. If you are dehydrated, your body is going to secrete antidiuretic hormone, which is the same thing as vasopressin. Okay, and what it's going to do is try to maintain your hydration. It's going to signal your kidneys to not release all the water, to keep it. And it's also going to cause vasoconstriction. So those things together will hopefully increase, your blood pressure, your perfusion. Those things kick in when we're dehydrated. Okay, and then hemodialysis, we have said, is filtering of the waste out of the blood through a machine. Right? Those are our cellular spaces here. We've got intravascular, intracellular, and interstitial is between. I talked about that. I drew a picture over there. We talked about that last week. This, compare and contrast. You did your system disorder. This works to death. You should have a great handle on overload versus deficit. Some more vocab here. Constipation, we know, is difficulty moving bowels. Crohn's disease, diverticulosis. tuberculosis, diverticulitis, irritable bowel, and on the other side is ulcerative colitis. Those are all inflammatory conditions. Diverticulosis is little sacs that occur in the colon. And then if you have diverticulitis, that's inflammation of those sacs or pouches because food or something has gotten stuck in them. All of those conditions, we worry about malabsorption, again, because they usually result in abdominal pain, nausea, vomiting, diarrhea, any of that. And we worry about the need for surgery. So these are our patients that may eventually have an ostomy, and where it's located just depends on where the damage is and what they have to remove. And then lastly, now we worry about bleeding and then cancer. Okay, so as these conditions progress, we're looking at hemorrhage because of the inflammation, because of the irritation. These are GI bleed patients. And then if that keeps occurring, we worry about it progressing to cancer. Kind of know about these different types of incontinence, retention. Create a case study. We went through all these with our activities. We did a case study on constipation, diarrhea, obstruction, GI bleed. And for urinary, we went through UTI, retention, and stress incontinence specifically. Okay? And that's everything, okay? And again, you guys have this now. It is right here for you in week 11 lecture, care plan, study guide, med sheets, and system. Woo, we did it. All right, guys, have a good week. If the